Assalamu alaikum. Thank you for inviting me, and thank you so much for being here today on Saturday. Okay, so today my talk will be how we can diagnose the MDS in easy way, and what are the challenges that we're facing or encounter along the way. Nothing to disclosure. So I would like to start with the basic information about the MDS, then when to suspect MDS, and how we can diagnose the MDS, or actually what are the diagnostic criteria for the MDS. And later on, there is few conditions that mimic MDS, and these conditions can be clonal and non-clonal. And to know or differentiate these conditions from truly MDS is very important because the treatment is totally different. And finally, we can touch how gene mutation will help us to make a diagnosis, especially if we don't have a support from the morphology and from the karyotype. So MDS represent a heterogeneous clonal hematopoietic disorder derived from an abnormal multipotent progenitor cells. And it's characterized by unexplained cytopenias, ineffective hematopoiesis, hyperproliferative bone marrow, dysplasia of cellular elements, and increased risk to the acute leukemia. As you know, you should exclude all the secondary causes for the cytopenia and dysplasia before you made the diagnosis, or you won't like to jump to the MDS. And these causes include vitamin deficiency, viral infection, mineral deficiency, and some toxin substance like alcohol, certain medication, and also autoimmune disorders. Age considered the greatest risk factor for the patient who have MDS. And the older patient or older people, they are at the risk to develop MDS. And as you can see, the inflection point is somewhere in the 60s. And the average age for the people who have MDS is somewhere in the 70s. Again, some patients at the risk to develop MDS, especially those patients who receive genotoxic treatment like radiotherapy, chemotherapy for prior cancer, or even normal people who are exposed to environmental toxin. Some cases can be familial and congenital, where gene mutation inherited in those people and make them predisposed to develop MDS. However, or although it's not necessarily for those patients to develop MDS, really MDS in the future. So this is NCCN guideline. This is the recommendation from the NCCN guideline when you're facing a patient and you're suspecting a patient have a MDS. So as you can see, most of the lab tests or things that mentioned here, it's nothing to do with the MDS. But again, we have to exclude all secondary causes. So after we exclude all the secondary causes, and patients still have a cytopenia, and you cannot explain why patients still have a persistent cytopenia, so we can do bone marrow. And eventually you have two end results for this. Either you can establish the diagnosis of the MDS based on the morphology and cytogenetic, along with the clinical criteria, or the diagnosis, it will not reach. Why? Because the criteria doesn't met, but still the patient has cytopenia. In this point, it might genetic testing help and push the pathologist and the physician to make a diagnosis of the MDS. So cytopenia per se, it's not enough to diagnose MDS. Again, as we said, we have to exclude all the secondary causes. And then we do bone marrow. Why we are doing bone marrow? To have a chance to do certain tests that will help us, or feature that can help us to make a diagnosis. And these are what we call it MDS marrow decisive criteria that include more than 10% dysplastic cells in one or more lineage, 5 to 19% blast, and abnormal specific karyotype abnormalities. And recently there is few specific gene mutation can help to make the diagnosis of the MDS. So the essential test that we use usually to diagnose MDS is bone marrow aspiration and biopsy examination through the morphology to assess the blast number, dysplasia, cellularity of the bone marrow, flow cytometry. Again, as Dr. Nahla, she said, the gold standard for blast enumeration is morphology, but here we can use the flow just to see what are the immunophenotypic dysplasia. For example, the apparent marker, the pattern of the cells, and it's simple. As you know, neutrophils express CD10. So while you examine CD10, neutrophils and there is loss of CD10, so this is evidence that neutrophils is dysplastic, not expressing normal marker. Karyotype, of course, is very important in the patient who's evaluating for the MDS, FISH, and DNA sequencing. So nowadays, NGS become a standard care for the MDS patient. It's important to mention not all the dysplastic features mean the same. There is few abnormal features, it's weight more or correlate more with the MDS. One of these, our rods. So if you have our rods, so that means the patient has myeloid neoplasm. At least MDS with XS+2 or even AML. Okay? The second one, increased number of blasts. Number 3, megakaryocyte, which consider pretty much more pathognomic for the dysplasia, and ring sideroblast. So I usually encourage my colleague to specify why they are describing a bone marrow aspirate, to mention what are these specific dysplasia. Because sometimes you will see in the report only mild dysplasia, touch of dysplasia. Mentioning specific feature, it will help a clinician also to know, is it more specific feature for the dysplasia or only find that you can see it with any condition, for example, iron deficiency or folate deficiency or viral infection also. So there is a study, very beautiful study, that done on the, around more than 1,000 patients with the MDS. And the idea of the study just to see how the concordance or the agreement between different hematopathologists while they are assessing different morphological feature. So they collect more than 1,000 patients with the MDS and they review their smears by qualified hematopathologists. Then they discriminate power feature, or they give a weight for different morphological feature, and they weight it, and they use something called K coefficient, which is inter-observer agreement, and they found more than 90% there was agreement between the pathologists. And they start giving a weight for few features, like I mentioned before, ring sideroblast, giving 3, myeloblast, 3, our rods, 3, and micromegakaryocyte, 3. So that's mean these 4 features very specific for the dysplasia. So this study, they make this study and they start scoring a dysplasia and to make it more standard to be used by the hematopathologist in the clinical practice. This is how I look at the MDS. It's a kind of a disease which is surrounded by different spectrum of disorder. So knowing clonal and non-clonal disorder that mimic MDS is very important. As we said, the treatment is totally different. Okay? So the WHO accepts certain abnormal chromosomal abnormalities as a presumptive evidence for the MDS. And as you can see, these are the abnormal that we can see it frequently with the MDS. And we can use these abnormalities even if there is no dysplasia or significant dysplasia as a presumptive evidence to diagnose MDS. But as you can see, there is few missing chromosomal abnormality, which is common also in the MDS, like deletion 20q and trisomy 8. But these abnormalities can be common with the other myeloid neoplasm. So we cannot use these as a presumptive evidence for the MDS. So this is why these chromosomal abnormalities is kept away from the cytogenetic or specific cytogenetic abnormality for the MDS. The other one is loss of Y, which is common in the elderly people. So presence of the loss of Y in the elderly patient, for example, you never know if it's original clone or something he had it before. So this figure illustrates the mutational landscape for the MDS, and here are the top 40 mutation, gene mutation that you can see it with in the MDS, and the size of the bubble just to show you how frequent or how common these mutation in the MDS. So if you look at the gene mutation distribution in the MDS, you will see it's totally different than the other myeloid neoplasm. So from this figure, you can see there is no single gene mutation in the majority of the cases. And the 6 most frequently mutated genes in MDS were mutated in only more than 10% of the cases. And the rest, less than 10% and even less than 5%. And most mutated genes can also be found in the other disorder. So that means these gene mutations lack a frequency, well specificity that enough to serve as a presumptive evidence for the MDS. So this is why usually when we read the gene mutation report or the NGS report, usually we read it integrated with the other lab test, with the morphology, with the karyotype, not as it is. For example, the patient has this type of mutation, so that means this is MDS. One of the challenges that the physician he faces in his clinical practice is how to interpret the mutation, or gene mutation. So ASH, they came up with, they built up group work, and they to help people to annotate this gene mutation. So they reviewed a variant observed in all the patients. They determined appropriate classification, and they described the clinical significance for these common mutations that you can be seen in the myeloid neoplasm, giving a disease association, germline risk, resistant association, prognostic significance, and therapeutic association also. And this work is already launched in the ASH website, and everybody can go and check this very beautiful work. Going back to the 5th edition for the WHO of MDS. Actually, the classification of the MDS, it's not really rely on the gene mutation or in the genetic marker. So as you can see, we have MDS 5Q since long time ago, and few years back, they just add SF3B1 under certain condition, which is no blast, presence of anemia, and presence of ring sideroblast. And recently they add TB53. So the question, why is still MDS not classified based on the gene mutation like AML? I think one of the reason is they have to look for the clinical significance of this mutation on the or clinical impact for this gene mutation on the patient. The other one, sometimes you can find mutation in the MDS people with low allelic frequency, and you cannot guarantee these are from the major or from the disease clone. Maybe it's something hiding behind, which is called CHEP, clonal hematopoiesis of undetermined potential. So during the past 10 years, few terms pre-MDS process came up, and these are ECAS, EDAS, CHEP, CCAS, and MDS. And it can be classified or subdivided based on the presence of the cytopenia, ECAS or CCAS, or in the absence of the cytopenia, EDAS and CHEP. Also, it can be classified based on the somatic mutation, negative ECAS and EDAS, and positive CCAS and MDS, and also CHEP. So again, CHEP is very important to be identified while you're evaluating patients with the MDS. So as we said, the CHEP incidence is increased while age increase also. And the more common feature or CHEP characterized by single gene mutation, low variant allelic frequency, usually 2 to 10, okay? And the more common gene mutation is DMT3A, TET2, and SXL1. While mutations that involve in the MDS or even CCAS, usually they are more than 2 mutations, and they have high allelic frequency, usually more than 10%, and usually they involve in more specific subclasses of the gene mutation, which is splicing factor, EZH2, RONX, and epigenetic factors. This is one of the most challenging or overlap between MDS and AML. So every time I receive call from the colleague, you mentioned 18% plus. Is it MDS excess plus 2 or it's AML? So why? As Dr. Nahla mentioned, because they draw a line, arbitrary line, which is 20%, a cutoff. So anything below 20%, it's MDS. Anything beyond or more than 20%, it's acute leukemia. And by the way, this boundary doesn't reflect any defined biological process. But again, how we can help the physician to make his decision because he want to start to treat a patient as an AML or as an MDS, or he have a lot of plan. And he need, especially when you count the blast and it reach only 18%, 19%. Okay? So one of the important things that we can do is to look at the gene mutation distribution among these two diseases. So as you can see, the MDS mainly defined by mutation in the epigenetic and splicing factor, like TET2, SF3B1. While in the AML is usually in the growth factor, like FLT3. And also, if you can see DMT3A, it's common in both, but it's more overexpressed and have more high allelic frequency with the AML compared to the MDS. And there is few mutation which is very specific for AML, like MPM1. So if you have a case, blast count it's 15, and there is dysplasia, and you found MPM1, so you have two choices. Either this is straightforward AML with MPM1 mutation, or if you would like to call it MDS because of the blast count, believe me, it will be eminent, and during few days, maybe 3 days, week, it will transform to the AML. So MDS diagnosis summary. MDS can be challenging to the diagnosis as finding can be subtle, resemble other neoplasm, and mimic by benign condition. And presence of clonality will help to establish the diagnosis when all finding interpreted in the appropriate clinical context. So please, never read NGS report without integrated with the other test. You have to integrate the molecular report with the karyotype, with the bone marrow biopsy report to define exactly what patient he has. Because, as I said, sometimes many mutation, it can be hidden in the back of the major clone and it's chipped, and it's nothing to do with the MDS. Finally, NGS testing at the diagnosis and even in the follow-up become the standard care for the MDS globally. Thank you.